connections that you were drawing between all of these other factors, the economy, and war, and natural disasters, and other types of stressors, because it's all interrelated. Here in the United States, obviously there are a lot of differences, but there are also similarities that we face. And I am very happy to introduce Dr. Maurice Wright, who is the medical director of the Harlem Hospital Center. He is going to share with us what he sees from a very important vantage point, and will offer a really interesting perspective. Please welcome Dr. Wright.
Good afternoon, everyone. You know, at first when Isabel asked me to participate, I'm like, why would I come to this facility to talk about something I'm no expert in? And then it took me a while. I thought about it, so I'll give you a little bit of my background and you'll understand why I'm standing here. So for 21 years of the ER doc, I saw the worst of everything. Things that I thought were totally preventable. And by the time I saw them, I wished I had seen them many years before. When I left the private sector, I worked a little bit away from here, about a block away from here. I went to the public system for a reason. I made that decision because what I think the name now represents is really true. It talks about New York City health. So I spent most of my time in college in the Bronx, medical school in the Bronx, training Upper West Side, I call it West Side of Harlem. And add to that, hospitals. Now, in the culture I'm from, when you say hospitals, everybody run. Nobody wants to go there. So I grew up on an island called Jamaica. Yeah. And I used to divert. If I was coming down the road and I was going to pass the hospital, I would divert them. Just because you all associate hospital with that of town. So when New York City decided to change and focus on health and hospitals being second, that's really smart. Because now that I'm no longer ER doc seeing the worst of presentations, getting to be involved in developing health from especially the young ages, getting folks to realize how important their health is, became much more of a pleasant journey. So I left that emergency world behind to take on a role at New York City Health and Hospitals, Harlem, for a reason. At first it was to get us our system there in a little better shape. I saw my old boss a minute ago. I want to shout her out, Jenny Suarez. And there's a particular slide that I'm going to call her name again about. But I wanted to point that one section out because I think it is so much more than we recognize, health and hospitals. Now let's hope I get this right. There we go. So in 2016, an assessment was done of Central Harlem. It actually felt like it was a WHO project because what I saw on the slides from Dr. Menafee was pretty much what I have seen in Central Harlem. High blood pressure, diabetes, asthma, obesity, heart disease, mental illness, HIV/AIDS, and going down the list. And the prevalence actually for that year follows the same order. Now when I was in the ER, one of the things that I saw daily was blood pressure out of control, which resulted in strokes, which resulted in heart attacks. And I would say, even to my own family, you have to take care of yourselves and control your blood pressure. And how do you do this? And explain it. But it was a very hard message to deliver. Our community loves salt. Our community don't like to take medication. Our community want to use some things sometimes that don't work. And so, as a physician, especially with that in my background, it became a very important task to challenge. Vis-a-vis why I thought public health system would be a fertile ground for improving health. When you look at some of the issues that we face, smoking, violence, we know what that does. Most of our young people that we lost, either to mental health or to violence, is preventable. If you get them in the right frame of mind, first of all, and if you really counsel them well. I'm learning more and more about the preventative edge on cancer. And we'll talk a little bit more about that. So this disparity that we are addressing, and I really push this one out there because, again, that fear of a hospital, we are actually working on a lot more called preventative health care. And that is, to me, more important sometimes than trying to treat at the end. You know, I have one brief story. I remember seeing this one gentleman in the emergency department, and I examined him, and when I examined him, I knew then and there that he had a terminal disease, right? And I knew this was preventable. If he had only gone and gotten a colonoscopy. And I said to another physician, I said, why do you think that this patient didn't get a colonoscopy and didn't get one at an earlier age than this result? And he said the fear of the procedure. Well, that physician don't know is that I was so fearful that I learned a lesson by taking care of this patient. You know what I did? I went to the back room and called my doctor and I said, yes, I'm up for it now. Sign me up. I had it. And sometimes it's not as dramatic as that, but educating our patients in a preventative manner serves us well. So I'm going to tell you about two real near and dear projects to my heart. One is high blood pressure, and how we used to approach it, how we used to look at it, and how we do it today. So there's this program that we call Treat to Target. But the first thing you need to do is to get the patient to buy in. So in the old days, it was, here's your medication, take it, see me in 3 months. I'm not if I could be real lucky. Because sometimes they never kept the appointment in 3 months, so you got another 3 months. And sometimes a year would go by before you saw that patient again. And so we changed the model. We changed the model to say, if someone has blood pressure out of control, or high blood pressure, or hypertension, we have to approach it differently. So that educating the patient phase becomes not just a one visit, It starts with that visit. There's a hypertension clinic, there's a hypertension nurse. You don't have to see the doctor the next time and the next time. You come in every 2 weeks, you get your blood pressure checked, and you get feedback based upon how you're doing. The patient can also call in, say, I'm taking the medicine, I'm doing some home monitoring, it doesn't seem to work. And so, we noticed that if we got patients involved in their own care and educate them really well over time, their attitudes change, which was the biggest win for health. Also, some medications do have side effects. Now, I have to admit to this one. Initially in my career, if I was going to start a medication, there were certain side effects that I didn't really want to get deep into. Because I knew that the patient would say, oh no, not me. But what we found out is if you educate patients clearly about the advantages, you're going to have a much better situation. And so, when I arrived after my ER career in Brooklyn, and initially in Manhattan, when I arrived back in Harlem, we were somewhere between 57 and 61% control, which is actually a little bit better than the national control for hypertension in that demographics across the country. But we didn't consider this to be success. It meant up to 40% of our patients were out of control and weren't being followed. And so we drove a very different system with the Treat to Target program. And over the years, no, the Treat to Target actually started before 2010. But it was started somewhere back in the 30%. So when I got there, the journey had started, but we didn't figure it was vigorous enough. With the help of New York City Health and Hospitals leadership, we were able to progress this because it takes a significant amount of resources. And today, when you look across the city, we still have work to do, we're now up in the 70th percentile. And when you look at some of our other facilities, you'll see them even doing better. But what does that mean long term? We've given the patients the power to help themselves with this Treat to Target program, and we are performing better than the national rate. If you move to some of the things that it involves, I mentioned the first two, but the rest which I've really and truly focused on in a different way now from the overall director's point of view is to get our mid-level providers and our nurses involved in helping the patient from making sure they know how to do their blood pressures at home, using the monitoring devices to do that, calling, doing care management, where we actually call the patient at home to find out how they're doing and see how that compliance is going. And to frequently, if need be, adjust their medication. And with that, we also ask family members or caretakers to be involved with the patient with allowance. That's the agreement we signed with the patient. It's a verbal agreement, but we reached that agreement and we noticed that improvement. If you look at diabetes, and I made this simple. It's the same principle. Hemoglobin A1Cs in 2012 were somewhere about 53%. And to be honest with you, we were still seeing significant reanimations, recidivism, secondary to diabetes. One of the most deadly diseases is diabetes out of control. And we know how to control it. But it takes a lot of patient involvement, it takes a lot of education, and the number one thing you have to talk about before you get to the medications and what the disease can do is what diabetes is and how most of us or most patients get here. And that's the diet talk. You want to see patients close down quickly? Start telling me I can't go get some Jamaican patties. What is it full of? Salt. What do I have? High blood pressure. Do I make anybody in the healthcare industry see me when I go in? No, and they don't know how much I leave with. But we know that if we are each other's keeper, especially at home, it's better. So my brother walks in, opens my refrigerator, and the first thing he throws in the garbage are my patties. So I have kind of a similar trick because I have a diabetic in my household who loves carbohydrates. Have what we call the Caribbean tongue. Carbohydrates, salt, and sugar. And when I tell her, this is no good for you, Mom, you can't eat it, I then prepare to run. But guess what I'm running with? But you know, a little bit and a by little bit. And by the way, Mom, 32 years of being a nurse, so she knows. But you have to help along the way. This is where the family connections help the patients, where education really helps. Where the young folks going home know what diabetes is and help those family members. Fresh fruits and vegetables and so forth. And we'll get to that side, which I love a lot. But again, it starts with the patient, their surroundings, their environment, their foods, their medication compliance, and making sure they're thinking in a very preventative manner. So, what did Central Harlem do? By the way, let me just tell you a little bit about this. In our registry for diabetes, there's 4,000 patients. And we noticed this last year, our results, we shot second in the health system. I'm not going to say hospital system because this is preventative. In the health system, we shot up second in New York City, in Central Harlem. Do you know how hard that is? And we hope to sustain it. Now, to my old boss, I say thank you a lot, because in that journey, Dennis, stand up for a second. Thank you. I have to tell you that when Denise said to me, Denise and I worked for a number of years together at the hospital, when she said to me they were starting a farmer's market, I didn't expect to see such variety and choices to the point where I go down and do some shopping. But I'll tell you, let me speak first about how easy it is to get the things that are not good for you, and how hard it is to get the things that are good for you. You go into any local shop in Central Harlem, you can get a beer, sorry. You can get some chips, you can get all of the sweet things that are no good for you. Try finding some nice fresh vegetables. And so this has been a prize outside the hospital on Lennox for most of the year except for the cold winter months. And I can't wait for them to start up again. And as you can see, it gives a lot of choices. But you know what it is? It's an example in the community about what the community needs. And so we preach really well to our patients about eating right. And by the way, yes, there is nutrition counseling, not enough, but we do that on the premises. But we have some major challenges. And I want to mention these because it takes a lot of us to address this. All right? Obesity, still nationally not well approached. One where we have to work in a very similar manner to prevent it. Once it happens, it is hard. Yet we know that health-wise, if you start, especially in the young teen years, to watch this, you will have better outcomes in health. I'm glad, and I'm not going to say much about mental health, but again, not one where I think we have a lot of experts to help, but not one that is well understood, especially by our community. By the way, the stigma that was associated with mental health has really decreased. That stigma has decreased. And we need to screen and get patients into care. I just wish that it would be better organized, especially across the country, but especially in New York City, where they can see psychotherapists and get the right care earlier. And I think we'd alleviate a lot of issues secondary to that. So, in concluding, when patients are empowered to be an acute participant, an active participant in all aspects of care, our health outcomes are significantly better. The systems must assist by providing open access. That means you can get in. If it is a blood pressure check, if it's a nutrition counseling, if it's psychotherapy, that you can get in to the system. You don't have to be at a hospital to receive optimal care. The impact of lifestyle habits, especially for our young folks, very, very important. All right? Every time I see my younger ones eating all these chips and so forth, and I talk to them, they smile. I say, I hope you smile a couple of years from now when your pants can't fit you. All of a sudden, you get a little bit of attention. All right? You have to educate your patients about what's going on. And to develop a better system, we have to have community partners that share this journey and the challenge. And with that, I just want to mention, all right, that there's some barriers that are beyond our bounds. All right? Nationally, making sure folks are insured. All right? Removing language barriers, getting over the financial challenges. And as we remove these challenges, again, we'll see that disparity decrease. Thanks, everybody. Have a good afternoon.